Hands. Who has heard of doorways or hub and spoke? All right, good. We'll go quick, or quickly. So first of all, this is the DH hub table, or a lot of hubbers over here. And as we get into the Q&A period, we'll ask our expert hubbers from Lebanon to answer questions. And do you have anyone from your hub here?
Well, I have one person, myself and Eileen. We have one hub employee, and he's actually sick today. So It was a scramble at 5:50 a.m. to make sure we had coverage. So we are in different places, trying to do the same thing.
So, as you know, a large sum of money has come to the state of New Hampshire, not only in the form of the DSRIP and all the work that we're doing, but also additional funds coming from SAMHSA, the Substance Abuse Mental Health Service Association.
Health Services
Administration. Funds that are coming roughly $40 million from 2019 through 2020. So all of this funding, we've already been talking about sustainability, both the SOAR program, State Opioid Response, and the DSRIP, who we are right here, Delivery System Reform Incentive Payment, 1115, all end in December, on December 31st, 2020. So we've got lots of work to do on sustainability. The SOAR funding, there was a portion of the SOAR, State Opioid Response Funding, that went to standing up 9 hubs in the state of New Hampshire. The governor said, I don't want anyone in the state of New Hampshire to have to travel more than 1 hour to get the assistance they need with substance use disorders, specifically opioid use disorders. So 9 hubs were stood up. Dartmouth-Hitchcock, there's the hub right there. Dartmouth-Hitchcock was 1 hub. Cheshire Medical was 1 hub. And I just want to show that this map highlights to you the overlap between these programs. This on your left is us. Here we are, Region 1, Monadnock, Sullivan, and Upper Valley. And on the right are you can see the 2 hubs on the western side that are filling the Region 1, IDN 1, are Dartmouth-Hitchcock and Cheshire Medical. So to me, this is exciting, additional money to do the work that we're trying to do. It also shows, like Danger, Danger, Will Robinson. We have the concern about getting out of alignment, duplication of services, miscoordination, confusion for our patients, our clients, not only to mention confusion for us. So mostly what I want you to know is that Shawn and I are locking elbows together. We're working continuously with the IDN Executive Committee members as well, and all of you to make sure that we don't duplicate and that we really use all of these precious resources to the best of our ability. Our IDN project is focused on the Medicaid population, but those of you who were in this room in 2016, remember, actually it was that room over there, Jose and I stood up and said, what we do for Medicaid, we want to do for anyone in need. So the infrastructure that you're building is going to serve all patients. The SOAR money, the Doorways program, hub and spoke, is not for a specific insured population, it's for anyone.
This slide just highlights the key concepts, if you will, for the hub and spoke model. So there's the 211 phone system's been around for information for a long time. The state has contracted with 211 to expand their capacity, and it's specifically, and when anybody calls 211 now, and if there's any indication of alcohol or some other kind of substance use issue, then they are, there's a live handoff, it's called, during the day to the hub where that person who's making the phone call is, saying they live. And the hub, someone at the hub answers that call and with the operator from 211 and then initiates their contact with that with that client, that person seeking some help. In addition, though, very importantly, is that the state has invested in 24/7 coverage for those folks calling with any kind of substance use disorder. And Dartmouth-Hitchcock Health System has embraced the role of providing the after-hours call coverage. So nights, weekends, holidays, there's a team of people that many sitting at that table have helped to organize. And then what happens at the ground level of a hub is, like on Monday morning, we got an email that we had 4 calls last weekend, and then I was working, so I had a phone conversation to hear briefly about the 4 individuals, and then received an email with more detailed notes about those individuals. So we, as the hub, can then follow up with those folks who called in on the weekend. So it's really a great resource, I think, and well, this is a diagram that shows it even more visually, I guess, in the path. And so we communicate as the 9 hubs with 211, the Dartmouth-Hitchcock Health after-hours call service, in terms of building the system. I think one thing I would suggest we're going to learn, or we're learning it already, is not surprisingly, there are a lot of gaps in terms of, particularly in terms of spokes. So the good news about what Sally said, the $40 million, some of it, a portion was invested in us. The state also has about 12 requests for proposals out in various stages to augment the spokes, because the hubs aren't necessarily, I mean, not all of them are actual treatment centers in their location.
And if you could just very quickly, here it outlines what the hub services are. As Shawn just mentioned, the hubs are not required to provide opioid use disorder treatment. They're really required to be the coordinating center. And I think the next slide maybe even be more representative. This is really about making it easy to get treatment. Dial 211 or show up at a hub. I need help. An assessment is made, referrals are made, and then that hub is responsible for making sure that that patient has case management in place so that all the services, all the needs of that patient are being met. Dartmouth-Hitchcock's a little bit unusual in that the hub lives at the addiction treatment program, so they can actually provide the opioid use disorder treatment, but that is not a requirement of all the hubs. So I just want to leave you with I think what I really want to leave you with is the promise that we are going to minimize confusion, to align resources, and to be good stewards of these resources that are being distributed through different programs, but hitting often the same people. And I would say of the hub and spoke, we have way more questions than we do answers, and we must learn from you. And we've all been working together since 2016. You'll have a lot of good ideas about how best we can fashion this so that we meet the needs of our patients as efficiently and effectively as possible. So questions, and we're going to talk to the hubbers when we get a question. Phil.
Sally, you said in that first slide with the 2 New Hampshire maps, right, that our region, the hub and spoke, lines up with the IDN stuff. Is that true of other regions as well?
No. Not all of them. It's, again, 7 IDNs and 9 hubs. So there's some overlap in some areas. I would say, I don't know, Shawn.
It's very different, as you can see, like the IDN region up north, or number 7 it's called, really encompasses parts of 3 different hubs. So it's not all aligned. We are pretty, as a region and as 2 hubs, we're probably one of the more aligned ones. Concord, Manchester, Nashville's, I think, has some alignment too with those.
See, then our alignment is a potential advantage for the future.
I would echo that 100%. We've been, as we've been going to these hub meetings, we have been saying we really want to make sure that we're lining things up. And
we're making progress. I mean,
I
the
think so,
two thoughts
yeah.
I have standing here and thinking about it is that the one thing when they did the district program several years ago, there was quite a bit of time and process to develop it. And then, as you heard from Mark, you know, it's almost like 2 years of building the runway or getting on it. We were called in late August to the first meeting to hear about what the state's idea of a hub and spoke was. And then we had that conversation for about conversations for 2 months. Then we got a contract on October 31st, and we had 2 months to open. So it's been a rather compressed process, and so lots of details are still being worked out. And if there's one thing about hub and spoke is you got to kind of go with the flow.
Go with the flow.
The other thing to be aware of, though, because we often, all of us use the term the state or DHHS. In reality, my sense is the DSRIP and all that came out of Medicaid, which is a element of the Department of Health and Human Services. The hub and spoke came out of the Department of Behavioral Health, which is a sub-department of the big DHHS. Obviously, they're all in the same complex or branch of government, but those conversations, just like, here, we're always constantly trying to improve our communication with all the partners in the room in the region. In big agencies like the state, the communication across these sub-department agencies and the governor's office can be highly variable. So we're all helping to, it's been a really good process to knit these things together, and we're building a lot off what we're able to do in Region 1 because we're so connected already.
Yeah. Peter?
Given the fact that we're on the west coast of New Hampshire, close to Vermont, it might be valuable just to make the distinction between the hub and spoke here and the hub and spoke concept in Vermont, because there's a lot of confusion about that.
That's a great point. The Vermont hub and spoke model is not the same thing as what New Hampshire has set up. The Vermont hub and spoke model, really, the hub is truly a hub for treatment. It provides direct treatment, and maybe even more importantly, it is the central resource for support for spokes who are providing treatment. I'm in trouble. I don't know what to do. Tyler is out in the spoke practice. He knows, he has the confidence and the security that he can get hold of someone at the hub and transfer a patient seamlessly to the hub. In addition, the Vermont model provides resources right at the point of care in the clinical practices, in the spokes. So they have a whole algorithm of how many resources are provided per patient in that clinic. That is not what the New Hampshire model has evolved to. We have a lot that we can learn from Vermont, and we have had a number of conversations. In fact, at our public forum, we actually asked someone who has studied the Vermont model to get up and say, what are the lessons learned from Vermont that we can row across the Connecticut River and implant here on the western side of New Hampshire? But there are some really fundamental differences in the models that we need to keep in mind. And again, the hub and spoke model here is being called doorway, so maybe we'll even have a whole brand new word so we don't get confused.
Yeah, in fact, there's a contract that the state has to brand it as the Doorway program with our organizational names, and that will start sometime in the next month or two. It's been good, actually, that they haven't been doing a huge amount of promotion given the complicating time frame to get us up and running and the ability to deliver the quality service. But I think the Doorway will help with the confusion about hub and spoke. I think of it, this came up at our public forum, and I think it's kind of in the spirit of New Hampshire, the live free or die state, that the hub and spoke system is evolving as to what it is. And in Vermont, it's got lots of algorithms and precisions, which is just different cultures in our state.
If you were going to consider going across the border and consult
with the Vermont Hub and Spoke. I would suggest, if you haven't done it already, to talk to folks in Massachusetts who have done a very similar thing in its own sort of machination, but it would be, I think it could be really useful. And as a border state, I've worked there for 30 plus years. I think you would find just south of us what is very similar is a system of providers that have been working together for a very, very long time before they adopted the hub and spoke model. So I think you might feel like you have a lot in common in terms of what you might draw from that experience.
So Hubbers, can you, Chris, maybe you could speak for the group. Any surprises that you've, well, anyone can speak. Can you give us just a sense of you've been in operation now almost a month.
Exactly.
Yeah, any sense of, any surprises that you can share with the group? Things that you didn't really expect and here and we're dealing with?
Well, I think whether it's a surprise or just our biggest challenge at this point is everyone's differing levels of understanding of what the rules, for lack of a better word, are, and the goal is to make things easier and provide more access. But there's times where people are taking the structure that they don't necessarily understand and applying too much rigor and rules to it. For example, a patient couldn't be admitted to an inpatient detox center without an assessment from the DH Lebanon Hub, which is not the case at all. And it took us 3 or 4 days to get that straightened out with that center to say, no, you can actually admit her directly. And if a patient presents at a spoke, and they're able to do an assessment, there's no reason why they shouldn't do the assessment because that's what's best for the patient at the time. Down the road, as we get more organized, that's when kind of MOUs, memos of understanding between the hubs and the spokes will get into place of how we can then together manage that patient or provide the information back to the state that they need while the care is being provided to the patient in the best place for them. So I think that's where there's still so much to learn everywhere, but what we keep, when we have our weekly calls with the state, keep bringing up, just remind ourselves the goal is easier access and more access for the patient, and not to get too hung up on what the hub is, what the spoke is, how the person gets care. I think it's great that the patients will ultimately have one phone number to remember, and they can call that, and they'll get connected to the hub who will give them resources. But if they by chance come across your name another way, they can absolutely self-refer still. So I think that's where the kind of surprising frustration of, no, you can just go. You don't need our blessing to do that. So, we do have that.
Yeah, I just wanted to comment. One thing that we've had about 40 individual contacts in our first month of January. Among those, we've only done 3 clinical evals that we're required to do as a hub for people to get into an actual treatment program. But what we're finding is both individuals with addiction and some of whom are in recovery or not, as well as family and friends are calling the hub because they're looking for help and information. So a woman I talked to on Monday who long-term, well not long-term, but she's 2 years on methadone, her kid just started elementary school, she's trying to get a job. She applied for jobs and she was calling because she'd never applied for a job online and she wanted who could help her to do that. So I thought, that's not really what we were talking about at the state meetings back in the summer, but I think that, that's the kind of, we have to be responsive to help people like that and be flexible.